Okay, welcome everyone to the afternoon session. And sorry we're a little bit behind schedule, but we're going to kick this off with the Martin Prince lecture. And I'm Martin Prince, and it's a privilege and honor for me to introduce one of the legends and giants in our field, Robert Edelman, who has been one of those unique individuals who's both clinical radiologist and physicist and has been innovating, introducing new techniques year after year. I remember 3 decades ago, his amazing non-contrast coronary MRA images published in New England Journal of Medicine, inspiring legions of teams to work on furthering, advancing coronary and cardiac MR. He's had his hand in developing black blood MRA with blood suppression methods, bright blood MRA with Epistar, and of course KISS is now a mainstay for evaluating peripheral MRA. He's been involved in Contrast Enhanced MRA, and many innovations that have just blown your mind about how he came up with that. So it is my great privilege and honor now to have Dr. Edelman give the opening lecture for our New Horizons session on the evolution of MRA.
Thank you, Martin. Martin, of course, is one of the giants in the field, having established Conscious Enhanced MRA angiography, and it's a great honor to be giving this actual second inaugural Martin Prince lecture. And I also want to congratulate Paul Finn and DBL and the people who are running this conference and the program committee, because this has just been so far a wonderful experience, and I am extremely grateful for being able to be here. So let's see, which way do I do this? Middle button? Okay. All right, so the title of my talk is Evolution of MRA Angiography. You can't talk about evolution without showing pictures of dinosaurs. But there's another point to this picture, which is that I see a lot of very young faces in this room, and you just don't know how lucky you are to be working with state-of-the-art MR equipment, because as I'll show you, where MRA angiography started from was extremely primitive and actually made dinosaurs look advanced. So what did we have to deal with? Well, you know, some of the first scanners were 0.02 Tesla. I did a lot of my early work on a 0.6 Tesla scanner, which at the time I was actually doing pulse programming on that thing. The magnets were slow. They had uncorrected or poorly corrected eddy currents. Imaging was slow. I remember when I was at Mass General, it would take 5 minutes to acquire 1 slice through the brain. And the only time I ever got a really good image of a brain was when a patient died on the table. So we don't want that happening anymore. We didn't have digital RF systems. I think back then, I don't even know if we had Apple II computers yet. No phase array coils, very basic pulse sequences, and no contrast agents until 1987. So a primitive landscape. Now, 1973 was an interesting year historically. This is when the U.S. ended its involvement in the Vietnam War. Things seemed the same. The price of oil doubled, same as this year. I'm from Chicago, so I had to mention that. The Alaska Oil Pipeline Bill was passed. American Graffiti premiered, and Roe versus Wade was passed and now overturned, of course. So, but back then, what was, of course, the big development was the invention of MRI by Paul Lauterbur. And when we consider MRI angiography, though, it actually predates the invention of MR imaging by a few decades, back to the 1950s. And we see references, Sirian, for instance, in 1951, and these really brilliant physicists laid the groundwork for everything that followed in the field of MR angiography. Now, in 1977, I think all of you know what the big event of 1977 was, right? Star Wars. So So, and, my life was changed fundamentally. I remember I was at Mass General walking into the theater and seeing that first spaceship go by, and my whole life was changed, and that probably inspired me to go on to do research. But the other thing that happened in 1977 was the invention of echoplanar imaging, which has had a lot of useful impacts in things like stroke imaging and all sorts of stuff. But perhaps for our field, what's really important is that Peter Mansfield, who was an absolutely brilliant and also a delightful human being, invented active gradient shielding, which then was used to facilitate all the advanced gradient systems that are essential to every MR angiography technique that we use today. So let's talk about some of the techniques that we now use, and we'll look at some of the techniques that are perhaps coming into the future. And this is a paper that I was only 3 years old at the time I contributed to this, but it was Van Wedeen, Reto Muley, and myself and others at Mass General published the first paper on MR angiography, and we were very proud of this, even though I think to anyone with decent eyesight it looks like trash. But it was the first subtractive technique, basically using diastolic and systolic imaging and subtracting the images. Very basic concept, but led the way to future development. And for instance, Miyazaki, who did absolutely brilliant pioneering work in the development of fresh blood imaging, that's really based to a large extent on that earlier work from 1985, 15 years earlier, but this time using more advanced pulse sequences, the fast spin echo type sequences. Time-of-flight MRA, probably we can date back even to the 1950s, but I would say one of the most important contributions was Larry Crook's paper in 1982, where he showed that there's a quantitative relationship between flow velocity and MR signal based on entry and exit effects, which is the basis for time-of-flight angiography. So not too impressive, the imaging there. I think he had a live mouse and a dead mouse, but given the technology of the time, it was pretty impressive. Then 5 years later, we see the first demonstration of using image processing in the way of multiplanar reconstruction combined with time-of-flight MRA to create images that kind of look like what we do today. And then we have two of the pioneers of the MATSA technique, multiple overlapping thin slab 3D time-of-flight MRA. Dennis Parker and Chun Wan are here today, I think. Some of them are here today. And just absolutely transformative work that lays the basis for much of the non-conscious carotid and intracranial angiography that's still done today. And that, in fact, we haven't seen the volumes of these procedures actually go down at our institution. That's still done routinely. This was just a little bit later, published in the New England Journal, and I guess it was easier to publish in the New England Journal back then because I don't think we'd get these images accepted today. But back then, this was groundbreaking. This was work showing that time-of-flight MR angiography could detect runoff vessels that you couldn't see with conventional X-ray angiography. We didn't have DSA there because Chuck Mistretta hadn't gotten around to inventing DSA yet. Or had you? I don't know what year that was. But this was a major work. And of course, we've seen peripheral MRAs not used as often because of CTA, but still used quite a bit. Phase-conscious MRA, we can date back to 1982 when Paul Moran showed that bipolar gradients could induce a phase shift that was dependent on flow. And then Chuck Dumoulin pioneered this work in 1986, showing that taking these bipolar gradients and doing image subtraction, you could create phase-conscious angiography. And then I wasn't even aware of this work until I started preparing this paper, but this was really impressive. 1996, one of the first time-resolved 3D phase contrast imaging, what we call 4D flow today. And it's actually pretty nice. I don't know how long it took to create those images, but now thanks, oops, sorry. Can we go back or? This one? Let's see. Can we go back one more? Or did I screw this up? Okay, let's try this one more time. There we go. So, the work by Michael Markle's group at Northwestern and others, have taken 4D flow to a hugely useful clinical tool and also a great investigative tool that I'm sure I've already seen. Many of you are actively involved in this field. So from relatively primitive early work to actually transformative, clinically useful work over a period of about 3 decades. Now, none of this current work would be possible without being able to go faster. And we couldn't go faster until Romer invented the phased array, which was back in 1990. And before that, we just had body coils and standard single element coils, which were fine for the time, but couldn't do much with. But as a result of him inventing phased array coils, then Dan Soderson in 1997 came up with the SMASH technique, which was the first real practical parallel imaging technique. Then Peter Jacobson and Mark Griswold went on to invent the GRAPPA technique. These are case-based versions. A year later, Klaus Prossmann invented the SENSE technique, which is an image-based version, and it's been nonstop progress since then. What's interesting, though, is that you may not realize that all the coil development that goes on now was largely because of parallel imaging. The need to create coil arrays that could let you go faster drove the field tremendously. And then you see things like this. This is an 8-fold accelerated coronary angiogram using parallel imaging. But then, of course, in 2007, Lustig applied compressed sensing to MRI, and this is a technique that relies on image sparsity, and this is now used widely, but back then was an absolutely transformative development. And here's some work from, I believe this is the Northwestern group, applying compressed sensing and showing how you can get even acceleration factors as high as 10 using compressed sensing because of the image sparsity. So this is critical work and really is allowing us to take things like 4D flow, which have such huge data sets, and getting it fast enough to be used in routine clinical work. Now, the important stuff. Conscious Enhanced MRA, Martin, this is your work. Is this your first paper?
Yep.
This at the time was like, huh? Why would you use gadolinium for MRA angiography? We had non-contrast, right? So I don't know that everyone jumped on this as soon as Martin published this, but it became clear pretty quickly that this was a much more powerful way of doing MRA angiography and it became absolutely transformative, and of course we use this all the time today. A few years later, Frank Kurasek and Tom Grist and coworkers at UW-Madison invented the view sharing. It wasn't the first view sharing approach, but it was the most effective view sharing approach, the TRIX technique that allowed people to do images where you separated things by time. And this is something like CT angiography still can't do very well. This is a big advantage for MR. And now, of course, we have very sophisticated implementations of this, can get beautiful, clinically useful, time-resolved angiograms with just a few cc's of contrast material. And then Meany and coworkers invented the stepping table technique that, of course, is used routinely for peripheral MRA. Martin had a big role in this as well, and that was published in 1999. However, of course, there was a rather shock to the system when people discovered that giving massive doses of gadolinium wasn't really healthy. We should have suspected that just from the fact that gadolinium is a calcium antagonist and has some sort of nasty physiological effects, but this is kind of something different. And so when NSF was discovered, we had to sort of step back and say, well, maybe we shouldn't triple or quadruple dose people with gadolinium, which is actually was pretty standard at the time. So the fact is that currently the risk of NSF is pretty much gone using macrocyclic agents, but our clinicians haven't necessarily accepted that. So our group actually published an early paper using ferromoxetol back in 2005, but it wasn't really until the UCLA group with Paul Finn pioneering the work and his coworkers that this became something that we all are very excited about. And ferromoxetol, of course, stays in the blood pool for like about 17 hours. And you can see these remarkable images in congenital heart disease, which is probably one of the biggest applications currently, but for venous disease and all sorts of things. And I'm looking forward to starting to use this much more in the future. All right, so given that, why bother developing non-contrast angiography? And there are a few reasons. One is, gadolinium still, there are concerns about it. Pharmoxol is rather costly, although I hear there's a generic version that's come out, I was just recently told. Still has a black box warning from the FDA. Our own hospital won't stock this in its formulary, which is a huge problem for us. So that's going to change, but for now, it would be helpful to have something that doesn't require any injections. So there's been a lot of progress in this area, and a lot of progress still needs to be made, but we're faster, we're more reliable, we've got all sorts of new techniques, and just from a research standpoint, it's just a very fun, exciting field to be in. So one of the earliest things was Inflowdependent MRA back in 2004, which was a 3D free-breathing technique. It's pretty remarkable, actually, and and in my experience, it's quite robust. This is state-of-the-art now, renal MRA. A lot of times it's even better quality than the Conscious Enhanced exam. So this is something we do routinely, and anyone who can't get gadolinium, and even if they can, we often start with this just to be safe. KISS technique, developed from my own group, is a pretty simple concept. It's basically you do gated 2D images acquired during diastole and apply an in-plane presaturation pulse to get rid of the background, and you can get some very nice images in about 5 to 10 minutes, covering the whole peripheral artery system. So that's become a pretty routine. It's actually a product on some vendors, and we use it pretty routinely. Now, arterial spin labeling is a very interesting area. It's used a lot by the brain researchers for looking at arterial perfusion, but you can also do MRA, and Dixon of the Dixon technique also happened to really pioneer this, showing projection angiograms back in 1986. And nowadays, you can get images that easily compete with the best contrast enhanced angiograms, and you can even do vessel selective imaging as shown here. So a lot of progress in the field. Our own group has done something kind of cute, which is we took a modification of the balanced steady state free precession technique called FIS, or fast imaging steady state precession, where we interrupt the echo chain periodically, and that gets rid of a lot of the flow artifacts that otherwise occur. We run this with a 2D ASL time resolved sequence, and you get some really kind of gorgeous images looking at blood flow patterns. So this is single breath hold. It's not competing with 4D flow in terms of quantification, but in terms of a quick look at flow patterns, it's pretty cool. Now, non-Cartesian MRA, so the FIS technique is a radial sequence. Interestingly, almost all the existing MRA sequences are Cartesian still, but that's not necessarily the way things should be. It's been shown early on by Gary Glover and others that radial sequences are pretty immune to flow and motion artifacts. You can do high acceleration factors with more acceptable fold-over artifacts, and so forth. And then, of course, Chuck, who's here, who not only pioneered DSA, but really pioneered the use of radial imaging, along with his group at UW Wisconsin. Unbelievable how good these images are. And this is using the Cush ball. I didn't even know what a Cush ball was until I saw this, but and then I couldn't spell it for another 5 years after that. But this is just showing with gadolinium that you can get great images, highly accelerated, and now probably an even more useful work is here by Kevin Johnson, showing the application to phase contrast. So it's interesting, though. I've started in my own work using radio for things that we didn't think of using radio before. So this is a patient who has a severe arrhythmia. We're trying to use this KISS technique, which normally works pretty well, but this patient, this is what we got. So I got called, of course. I was in the middle of something and got called and said, hey, your technique doesn't work. Can you come down and try to fix it? So I came down and said, okay, this sucks. Let's turn on radial and see what happens. So we just turned on a radial trajectory, and we got this. Same sequence, exactly the same pretty much, and we just turned on radial, all the artifacts went away. So that's something we've got to start doing more, is thinking about using these non-Cartesian trajectories. In fact, we took our FIS sequence and did a stack of stars, which is a 3D radio version. This is a nice this is a patient with a right renal artery stenosis. 4-minute free breathing scan looks fine, but this is a single breath hold. So we don't realize how fast we can go once we get rid of motion artifacts. And this is just using stack of stars, because if you try to do this with Cartesian, you're going to get all sorts of artifacts. Here's an example of doing a 3-dimensional KISS version developed by John Kotzeglu, doing a stack of stars with multiple slabs, overlapping slabs. So that early Matza technique, now converting it to a radio version, you can get beautiful images with this. And then John's even gone a step further, and he's going to show this, I think tomorrow. It's a quantitative stack of stars where you can, in the same time as you do the time-of-flight angiogram on the left, you also get quantification as shown on the right.
Yeah.
And then, of course, radio and stack of stars isn't the only thing.
I know.
There are things like spiral and so forth. How are we doing on time?
A few more minutes.
Okay. All right. So it's moving on to a little bit different animal, which is the imaging of atheroma and vascular calcifications. And this is really some pioneering work, I think from the London group, published 1989. And this was using a chemical shift technique to look at plaque. So this was one of the first investigators to think about using MR to look at plaque characteristics. Now, of course, thanks to Chun Wan and others, there's an abundant body of data and technical advances to show that we can really nicely characterize arterial plaque and potentially predict which patients are more likely to have adverse events and potentially help guide therapy. And this is something where I think MR is clearly advantageous over CT, at least in this vascular system. And then using 3D, variable flip angle turbospin echo techniques, people are now routinely looking at intracranial plaque, which is kind of an undiscovered country and something with a lot of potential applications. Now, there are other black blood or dark blood imaging techniques. For instance, this is the diffusion-prepared steady-state free precession work that was published in 2007, just showing a nice aortic arch. And here, the SNAP technique, which is a very interesting phase-based technique that gives you both bright and dark blood images, and I think it's got tremendous potential for analyzing plaque. Our own work, we sort of, I'm not that smart, so I like repurposing old things because I can't really come up with fundamentally new things. Oops, keeps doing that. Let's see if we can go back. And so I took a 30-year-old sequence, the FISP technique that probably many of you have never even heard of, and then said, well, you know, it didn't work then, but could we get it to work now? And what you can see is on the left is a balanced steady-state free precession in a patient with a mediastinal cyst. And on the right, this is a breath hold 3D FISP variant, what I call unbalanced steady-state free precession, that makes all the blood vessels dark, single breath hold, and then you can see the lesion very nicely. And this is potentially going to allow us to do a whole bunch of new things that we couldn't do before. But it's really taking a 30-year-old thing and then looking at it again with fresh eyes and saying, hey, maybe we can get it to work now. So just to conclude, not yet, sorry. Just want to mention calcification, because CT obviously is great for calcification. I think this was shown earlier today. But we do need to be able to identify calcifications, because if you're going to do an intervention, you don't necessarily want to stick a needle through a dense calcification to try to get into an artery. You may not be able to get through it, and then if you do get through it, it may bleed like heck. So MRA techniques, regular MRA techniques aren't very good. We used a proton density in phase, again, radio-based technique, a stack of stars technique, and you can see that in these images, everything is gray except the calcifications, which appear dark. And it makes it very easy to see the calcifications. And Giles Roditi's group did a very nice paper as well for looking at thoracic aortic calcification that was published recently. And in our work, we showed near perfect correlation between CT and MR using this. And there's been others, of course, that have done work in this area as well. So to conclude, we've come a long way from those primitive early days of MRA. The future looks bright and dark, I'd say, because I like dark blood imaging, if you get that. We're looking forward to better image quality, faster scans, higher spatial resolution, more physiologic information. But something we definitely need is a little bit more uniformity so that every MR scanner can do this stuff. And right now we don't have that. So looking forward to seeing the vendors pick up on that comment. And thanks very much for letting me speak today.